Hello, dear colleagues. Hello, Olena. I'm really glad to be a part of your event again. And I have extended my topic a little bit, and I will represent our nationwide high cardiovascular risk primary prevention program, as well as I will talk about our methods to detect FH patients. And lastly, I will represent our opportunities to manage our dyslipidemic patients. I have prepared this presentation together with Professor Žaneta Petrulionienė. I have nothing to disclose here. According to health statistics of Lithuania in 2023 and again in 2024, the main causes of death were circulatory system diseases, which also includes coronary heart disease, and this made up more than 50% of all death. So these numbers are one of the biggest in Europe for many years. Therefore, almost 20 years ago, in 2006, Lithuanian High Cardiovascular Risk Primary Prevention Program, or LIDHERE, was implemented, and until 2023, this program was available for all Lithuanian men from 40 to 54 of age, and for all Lithuanian women from 50 to 64 years without overt cardiovascular disease. However, recently it was recognized that CVD prevention measures are implemented too late, especially in the women population. Therefore, since 2023, LIDHERE program is available for all Lithuanian citizens between 40 to 60 years old without overt cardiovascular disease. The program has two-level approach. First, all Lithuanian primary healthcare institutions where family doctors determine persons' CVD risk, and very high-risk patients are being referred to cardiologist consultation in specialized CVD prevention units, which we have more than 30. In the frames of LIDHERE program, more than 260,000 individuals are being screened every year, and this covers almost 50% of our targeted population. We have almost 235,000 lipidograms in the database, and according to them, dyslipidemia is one of the main CVD risk factors in our country. Any type of dyslipidemia was present in almost 9 out of 10 patients. In comparison, in the US, this number is a bit more than 50%, and in Europe, almost 58%. Here you can see the graph of hypercholesterolemia from the LIDHERE program, where almost 235,000 lipidograms were analyzed. Median LDL cholesterol is 3.83 millimoles per liter, where females have higher numbers than males, and this may due to the difference of both genders' age. Talking about phenotypically like FH in Lithuania, we have also some data from LIDHERE analysis. At first, if we have the population of almost 2.7 million citizens, then the expected number of heterozygous FH would be almost 13.5 thousand people. If we assume that the prevalence is 1 in 200, and 17 people with homozygous FH, the prevalence is 1 in 160,000. If we look at LIDHERE program, the analysis of more than 123,000 lipidograms reveals that the prevalence of possible FH phenotype is 1 in 7.5, and the prevalence of probable FH phenotype is 1 in 73, and the definite FH phenotype is less common. Why we have such a great prevalence of possible FH cases? It may be due to, for example, founder effect, especially when we talk about Lithuania, and the number you see in this slide is very close to my previously mentioned statistics. However, the exact reasons of such great FH possibility in our country are still unknown. If we take into account clinically and or genetically diagnosed FH, then we should talk about 429 people included in Lithuanian long-term FH observation program, as well as into global registry. Every single patient has signed informed consent form for being included here, examined and detailed, and their data to be published in scientific literature. So most of these patients fall into possible FH group with a median LDL cholesterol concentration of 6.37 millimoles per liter. Next part will be FH screening in Lithuania. So Lithuania National FH Screening Program was implemented in 2016 and was created mainly on the basis of the LIDHER program. Since then, the selected patients have been included in Lithuanian FH long-term observation program, which is a part of European Atherosclerosis Society FH Studies Collaboration Global Registry. In Lithuania, the screening of FH is mainly based on opportunistic screening approach, guided by increased levels of LDL cholesterol and followed by family cascade screening of detected index cases. So we have a few ways to detect FH patient. Suspicion of FH rises when we detect LDL cholesterol equal to or more than 4. In the frames of LIDHER program, all Lithuanian citizens, regardless of age, with LDL cholesterol equal to or more than 5 millimoles per liter, can be referred for cardiologist consultation to the specialized cardiovascular prevention units for suspected FH. Here you can see the algorithm we use to detect and initiate further screening of FH patient. So when we have detected adult patient with increased LDL cholesterol, the patient is directed for cardiologist consultation. Then very detailed analysis is collected, physical examination is performed, and many lab tests as well as instrumental testing is being performed. This allows us to detect secondary causes of dyslipidemia, and these patients fall into unlikely FH category. The remaining patients have a clinical diagnosis of FH according to Dutch criteria. And then if the patient meets Dutch criteria for probable or definite FH, or his or her LDL cholesterol is equal to more than 6.5 millimoles per liter, he is referred for genetic testing. And cascade screening of first-degree relatives is also initiated. The genetic testing is reimbursed and performed either in Santaros Klinikos or in Santa Gene Laboratory in Germany. Why we have chosen these thresholds? Because according to published evidence, these thresholds have a high positive predictive value to detect FH-related mutation. The most common detected mutations in our patients' population are LDL receptor and ApoB mutations. We haven't detected any PCSK9 variants. However, we have 8% of other variants which are also somehow related to increased LDL cholesterol concentrations. To mention, all of our patients are heterozygous. A few patients are compound or double heterozygous, but none of the patients are homozygous. Talking about pediatric population, detection of FH cases among them is a bit different from adults. The diagnosis of FH here is based on increased LDL cholesterol when it's higher than 3.9 millimoles per liter and family history of FH or premature coronary artery disease. In 2020, Children's Hospital has become a part of a FH screening program, so in the frames of it, they perform detailed examination of children and reverse child-parent screening is initiated. What is more, in 2021, Center of Rare Diseases of Lithuania has received a grant for 1,000 children to be universally screened for FH. So we're waiting interesting results in the near future. There are a number of barriers which prohibits us from adequate management of FH. The main are lack of general awareness, different screening approaches and controversies about the best diagnostic criteria, absence of ICD code, because in Lithuania we still use E78.0 or 0.2. Moreover, extremely strict personal data protection rules reduce the possibility of enrolling patients in various registries, and genetic testing still remains of limited availability. Treatment of dyslipidemias in Lithuania is available with statins, which are reimbursed 100% for all dyslipidemic patients. These medications can be reimbursed by cardiologists, family doctors, internal medicine doctors for treatment initiation and for all lifelong. We have reimbursement for combinations of antihypertensives and statins, as well as ezetimibe with statins. PCSK9 inhibitors, inclisiran, are available, however not reimbursed yet. Plasmapheresis are available and reimbursed in major hospitals, and selective LDL apheresis is also available in major hospitals, however not reimbursed. The consumption of cholesterol-lowering medications in Lithuania still remains significantly lower than in Nordic countries. But the good news here are that due to improvement in drug reimbursement conditions, we have increasing sales of statins and polypills with statins every year. As well as we have reimbursement for ezetimibe and statins combination, and conditions of reimbursement are improving rapidly, so the sales are also growing very fast. Of course, there are a number of gaps between guidelines and clinical practice. They are nicely highlighted in the Eurospire clinical trial. First, only a minor part of the patients with coronary artery disease have optimal lipid management. Secondly, there is a need for more professional strategies to individualize treatment and lifestyle changes. And lastly, the good examples of well-managed patients give us a hope that present conditions can be improved. So the improvement of dyslipidemic patients could be reached by treatment individualization, initiation of lipid-lowering therapy as early as possible after acute coronary syndromes, keeping reach targets as long as possible, and usage of new innovative injectable drugs, as well as combinations versus high-dose monotherapy. Sending best greetings from Vilnius to Ukraine. Bye-bye.